So let's introduce our panelists. We have Amy Hodges first. She is our Cotiviti's AVP of Content Development. She leads a global team of doctors, nurses, and medical coders that create and maintain clinical coding edits for Cotiviti's payment accuracy solutions. This involves researching and understanding changes to national guidelines so that the edits are compliant, and then clients can pay their Medicare commercial claims accurately. Our second Amy is Amy Carlton. She's our RN and BSN and our Senior Director of Clinical Chart Validation. So with over 12 years of payment integrity experience, Amy Amy C supports our Cotiviti Clinical Chart Validation solution and those clients to help save improper spending on DRG, short stay, readmissions, SNF, IRF, outpatient. She directs product investments and developing new enhancements and audit types to support Cotiviti's long-term growth. Last but not least, we have Matthew Herbine. He's our VP of Data Mining with over 10 years of experience in healthcare payment integrity. Matthew leads pharmacy operations, the operational analytics team, and the Postpay strategy. He connects operations and sales to enhance payment integrity solutions, strengthen client partnerships, and drive competitive advantage. So for today's objectives, when I hear the words regulatory changes, these days anyway, what first comes to mind is how do we predict what effects the new administration might have on regulations and payment integrity for 2025? But I think we've all found that it's a little too early to draw any definitive conclusions there. So today we're going to stick to discussing official payment integrity mandates, a few of them, and then also a few data-driven trends that we're seeing here at Cotiviti and what we might be able to do about them. But one thing I think we can say for sure from the federal level is that there is a renewed focus on fraud, waste, and abuse. We've seen the articles. And preventing and recovering on fraud, waste, and abuse and errors, I think, is a huge part of why many of us are here. I think we're all used to seeing these stats now. 25% of annual healthcare spending, which is now at $5 trillion, is considered wasteful. NHCAA has not changed its estimates really from that 3 to 10% lost to fraud and abuse. And we have to, we in the payment integrity industry, we have to try and fight all of this in the face of constant change. So, for example, all the changes in the CPT codes and ICD and HCPCS, Cotiviti, we've updated a third of our entire policy rule set due to these changes alone. And that includes many thousands of rule changes, many more thousands of rule reviews. And I think Amy Hodges will probably have a thing or two to say about that in a moment. And while this is happening, billing trends continue to fluctuate. For example, according to Cotiviti data, there has been a steady increase over the last 5 years in telehealth level 4 and 5 E&M claims to the tune of 17%, while at the same time, level 1, 2, and 3 claims saw a decrease. Also, inpatient claim spend has dropped some 6%, while spend for outpatient has increased 4%. So what does that mean for us? I think Amy C might touch on that. And then last example of the changes, prescription drugs, drug spending is projected to increase some 8% in 2025, according to Health Affairs, with roughly 1/3 of that being on the medical benefit, which means medical drug spending also on the rise. And you can see with Cotiviti's data, we do verify that. So let's get into it. Enough setup. Let me address the first question to you, Amy Hodges. I think CPT code updates is quite the pain for many of us, for billing providers, for billing offices, payers, editing content teams. So last September, the AMA released the new CPT 2025 code set. According to their press release, quote, new technologies and cutting edge procedures spurred most of the annual changes. So Amy Hodges, can you just touch upon some of those changes, some of the major changes and how they might affect payment integrity vendors and payers and billers.
Yep, absolutely. Thanks, Warren. So the biggest change to CPT for 2025 is the new set of E&M codes for telehealth. The reason behind this change is it dates back to the COVID PHE, where providers started, we couldn't have the in-person visits anymore. So telehealth services expanded significantly. And unfortunately, the reimbursement and payment for all of these services were all over the place. There was no standardization. So last year, a joint CPT RUC work group, which brings the AMA and CMS together, it was formed to determine the valuation of these services. So the main question was, should the payment be in line with office visits, or should telehealth be at a reduced rate? The outcome of this work group was the AMA created a new group of telehealth codes, and that range is 98000 through 98015, and these were effective January 1st of this year. This new group of codes it's similar to office visits. It's structured like an office visit where it has new versus established patients. It also is grouped into audio only and audio video services. But to throw a little monkey wrench in it, for 2025, CMS decided that it will not recognize these new telehealth codes because they believe that the office visit codes with appropriate modifiers in place of service adequately distinguishes between in-person and virtual services. CMS has assigned them a status indicator of I in the fee schedule. So that means there's a more specific code that should be used for Medicare services. And that more specific code is the office visit codes with a modifier 95 for audio video visits or 93 for audio only visits. And then they should be performed in place of service 2, where that's when the patient is somewhere other than home, or place of service 10, where the telehealth is provided in the patient's home. This approach from Medicare was aimed to maintain payment parity between in-person and telehealth services and avoid the need for physicians to learn a new set of codes. But we all know the physicians are going to have to learn a new set of codes since the AMA made the decision to create that new set of telehealth codes. CMS has a list of approximately 250 codes that are approved for telehealth per CMS. The AMA also has a list in their appendix, Appendix P, that is the AMA's services that are allowed via telehealth. So these, at least the CMS list changes frequently, so it's important to monitor those for any changes. CMS is allowing the use of the new CPT code 98016, which is the virtual check-in. It was previously reported with HCPCS code G2012, and CMS has deleted that code. Something that happened fairly recently, so prior to the pandemic, there were very strict geographical and provider restrictions for telehealth. And during the pandemic, CMS provided lots of flexibilities so that providers, more telehealth could happen during the pandemic. These flexibilities were supposed to end on 3/31/25. But just over 10 days ago, on March 15th, Congress passed a bill that extends these flexibilities through the end of September of this year. So that's still giving providers a lot of flexibility in providing virtual care. So some of the things that are still covered are certain services like behavioral health and physical therapy. The providers can bill audio only services for those without access to video technology. The geographic site restrictions are no longer in place, so patients can receive telehealth from various locations. The federally qualified health centers and rural health clinics are eligible to provide telehealth services. And then it delays the implementation of in-person requirements for mental health services delivered via telehealth. So it's, just as of note, I mean, it seems like the telehealth reimbursement is kind of all over the place. And I think as soon as this whole process starts to mature, we will see some more standardization around these services. But it's critical for providers to verify your payers' policies and billing practices, since the coverage differs among all the payers. And back to
Okay.
you, Warren.
Okay, thanks. Yeah, I might ask you a little bit more on that, about maybe what we can do in a moment, but let's stick with the challenges for a minute. So Matt or Amy C, I'm guessing telehealth maybe not such an issue in the inpatient and outpatient facility world, but anything in your areas with CPT, or maybe it's something else entirely that you're seeing could affect payers.
Yeah, Warren, that's a great question. For the inpatient space and what Amy is talking about with telehealth, I'm just going to pause there and say that there's a lot going on with telehealth, as Amy had said, and where codes are changing. Things are being updated, policies, regulations. So the same thing occurs within the inpatient as well, is that we are seeing a change in regulations and keeping up with those to make sure billing is in line with what is being billed and documented within the charts. We're seeing that there is a movement to the intervention upstream to be able to perform reviews for inpatient claims into the prepay space. So traditionally, we have seen in the retrospective space the chart audits, but as we work and partner with the health plans, we're seeing that space intervention should be moving upstream to prepay for chart review. And additionally, we're also seeing that for outpatient, there's a shift there where we are seeing that you had mentioned earlier, Warren, about the change in spend going from inpatient to outpatient. We're looking at that as well as a market trend. We've been doing some interviews and we've also been doing research to see exactly what you shared about that spend shifting. How do we ensure that we are also looking at those that are in the outpatient realm, such as those procedures that have become less invasive? As a nurse myself, I am always thoroughly impressed with how procedures used to be inpatient only are now shifting to that outpatient space, that patients can get that treatment outpatient and go home the same day. But it is important on behalf of the health plans and providers that we do monitor how those are billed, and how the treatment that the patient may receive during that procedure, that we also ensure that it's following that billing and coding guidelines, because there could be potential areas for recoveries in there within that spend space increase. There are challenges with when shifting from inpatient to outpatient to having those specialty reviews being able to be supported. And so within our program, we are working with the expansion from inpatient only to reviews with the inpatient and outpatient setting to help support as the trend in the market is shifting, that we're able to support those capabilities. And Matt, I'm going to look to you and see what you have in your space in terms of those trends and challenges you may be seeing.
Thanks, Amy. So in our post-pay data mining audit, we're seeing the same shift in claim spend from inpatient to outpatient. More procedures are moving out of hospitals, and this shift is already evident in payer policies and provider strategies, creating both opportunities and challenges specifically for the post-pay review. So this increase in outpatient claims means there is a need for stronger analytics to monitor coding accuracy and adherence to updated reimbursement policies. Post-pay audit strategies must evolve to keep up. High-cost outpatient procedures, especially in orthopedics, cardiology, radiology, and those specialty pharmacy audits, require more targeted review logic and possibly policy updates. Also, site of service billing risks need to be addressed to prevent miscoding and unnecessary or excessive charges. Which actually brings me to a separate post-pay challenge that I wanted to call out, related to the latest updates to the hospital price transparency rule. So the hospital price transparency rule went into effect back in 2021. It required hospitals to publicly post standard charges, items, and services. Since then, CMS has rolled out several updates to improve standardization and strengthen compliance. And then most recently, effective actually at the start of this year, hospitals were required to expand their machine readable files, or MRFs, to include the following new data elements. And these were estimated allowed amounts, drug unit of measurement, drug type of measurement, and modifiers. And I also wanted to point out here, actually a helpful resource for health plans on this and hospitals is the CMS hosted webinar titled Encoding the January 1st, 2025 requirements in the machine readable file and tips for implementation. This actually aired this past October, and there's a publicly available document from this webinar that walks through these changes in detail and offers implementation guidance. And then also just last month, on February 25th, President Trump signed an executive order aimed at increasing enforcement of the healthcare price transparency regulations. It directs relevant departments to build a more rigorous compliance framework within 90 days to ensure compliance and standardization. Really, the goal is to make pricing data not just available, but standardized and easy to compare across hospitals and health plans. And I believe the administration expects these changes will empower patients, drive price competition, and reduce overall healthcare costs, while also helping health plans and providers improve reimbursement accuracy. And really keeping up with these changes will be critical in post-pay data mining audits as more granular pricing data becomes available. I also would like to touch on the ever-popular GLP-1s. Some may know them as Ozempic, Mounjaro, Wegovy, or Zepbound. And according to Becker's Hospital Review, several health plans have implemented policy updates effective earlier this year, at the start of the year. So Kaiser Permanente will drop base coverage for GLP-1s for Commercial and Affordable Care Act members in California when those drugs are prescribed solely for the purpose of weight loss for patients with BMI less than 40. Independence Blue Cross will cover weight loss drugs when prescribed for conditions. They'll only cover weight loss drugs when prescribed for conditions like type 2 diabetes or cardiovascular diseases. Blue Cross Blue Shield of Michigan is actually eliminating GLP-1 coverage for obesity. And this is going to actually affect 10,000 members in large group plans. Last payer I wanted to mention here, Point 32 Health within Maine and Rhode Island is introducing new formularies in 2025, removing some weight loss drugs and tightening prior authorization requirements. So with demand of these drugs continuing to rise, it's critical to monitor ongoing policy changes and their impact on coverage costs and utilization. Last point here I wanted to highlight before turning it back over to Warren. There's actually a clear and growing focus in payment integrity on shifting work upstream, right? You just heard Amy touch on it as well, from both really just post-pay to prepay. And plans are under pressure to reduce administration costs, provider abrasion, and time to recovery. And the longer a claim sits unreviewed, the harder it becomes to resolve. But that shift doesn't eliminate the need for post-pay. You still need the in-depth and breadth of post-pay analytics to catch what slips through, identify patterns, and drive policy improvements. I really believe the key here is integration. And that's why it's becoming more important to work with vendors who can support you across the full payment continuum, pre, post, and everything in between. From real-time claim edits and prepay hold logic to retrospective audits and root cause analytics, it's all connected. The more coordinated your approach, the more effective your program will be. And with that, I'll turn it back over to Warren.
Okay, couldn't agree more. So I think we could spend an hour just talking about GLP-1s or an hour just on transparency. This is a shortened time frame here, so I'm going to keep it moving, try and get a little bit into what can we do or what should we do, because I'm hearing telehealth code updates. We got medical drug increases, and you mentioned GLP-1s. We had the price transparency, the shift towards more outpatient facility. So just with those things in mind that you all mentioned, what should health plans, payment integrity vendors, others do? What should we be doing to kind of keep up with this, or better yet, stay ahead of it?
Yeah, so Warren, I'll jump in around what we should be doing, how you partner with a vendor. So with that, as I mentioned earlier about the outpatient reviews, I'll go and pause a minute and say, as a nurse, as I spoke earlier, it used to be inpatient, inpatient. A lot of things used to be inpatient. And so we have focused there within the chart audit realm. But with the advance of technology, with the use of AI in the actual procedure world, in the ways to advance and keep folks healthier longer, which we're thankful for. But we also know that being in an inpatient stay all the time isn't where it should be either. So how we can help is being able to analyze the data, being mindful of as the data is coming in, we're looking, where is that spend? What is the complexities? What are the rules and regulations within that? So with that, the outpatient reviews, the intervention point going from inpatient to outpatient for those procedures, the health plan should be tracking that and monitoring that and looking for a partner to help perform reviews within that space, because the data can be challenging. There could be more volume. They could be different lower paying claims, but at the end of the day, still value there to make sure that the billing is following the coding guidelines, the regulations. There's specialty reviews that need to occur. They are complex in that outpatient setting to ensure that you have the subject matter expert around the knowledge of how the claims should be billed, how they should group, what payment classification they could be grouped to. So such as Medicare's ambulatory payment classification, or what they call APC. There's some specialties in terms of not just performing the review clinically, but ensuring, again, it rolls up and is grouped to the right APC to hit the right payment classification. As Matt said about the whole pricing transparency, we want to, again, ensure that the treatment that patient received during their procedure is documented correctly, billed correctly, and then paid out correctly. And it's key to partner with a vendor that's able to support that and be able to help find those additional savings in that space. But that's just a piece of the puzzle. That's outpatient, but we also, do inpatient. So sitting again in the inpatient, outpatient realm, having that broader portfolio going from the DRG reviews to the skilled nursing facility reviews, to the inpatient rehabilitation reviews, the outpatient reviews. There's a lot of pockets of inventory within the healthcare paid space that we need to ensure is being looked at for accuracy, in line with the regulations and keeping up with the changes in regulations. Just like Amy and Matt have mentioned about telehealth and changes with drugs, the same thing occurs with how billing occurs with the inpatient or outpatient grouping of claims. There are adjustments always occurring. We want to ensure that we are supporting those. We're able to find those and partner with health plans to find those savings and be able to do that both in the inpatient and outpatient setting. So Matt, what are your thoughts as well of how else we could help?
Yeah, thanks, Amy. So from a data mining lens, health plans may look to consider a payment integrity partner that can move fast, adapt to shifting market dynamics, and deliver forward-looking insights. Really, that means having the tools, data, and scalability to keep up with how care is delivered, priced, and paid. Offering integrated solutions across the full claim payment continuum and operating with speed and flexibility to respond to all these new policies, billing patterns, and provider behaviors. Just as important, it's valuable to work with a partner that has a robust concept library and a consistent track record of innovation, one that doesn't just react to trends, but anticipates them and regularly brings forward new concepts for review. So take the most recent pricing transparency updates. It's important that vendors are actively leveraging the machine-readable pricing files that are now required from hospitals. As these files continue to evolve and include more and more detailed data elements, they open up new opportunities to validate claim accuracy and reimbursement. We all know contract compliance audits can be complex, but the updates being made to these files are just another essential tool in the payment integrity toolkit. At Cotiviti, we integrate these files into our validation logic to flag inflated charges, identify missing modifiers, and inconsistent pricing. And just last week, perfect timing here, our medical pharmacy team utilized 2 of the new data elements loaded into a hospital MRF to identify over $2 million in overpayments caused by a drug being billed per vial instead of per drug unit. This misbilling inflated the charge and payment amounts across multiple claims, creating that overpayment. Moving to a topic that we all have seen and it's been all over the news, GLP-1 policy changes will continue to evolve and are worth watching closely throughout 2025. It's reasonable for plans to look for a vendor who are really proactive and engaged across both prepay and postpay pharmacy audits. And here at Cotiviti, we're actively tracking these changes and are prepared to support alignment with all of these policy changes. My final point is that health plans might consider working with vendors that offer a true end-to-end solution with the ability to shift work upstream, really when it makes sense, and reduce friction across the claim lifecycle. And I really wanted to highlight 2 areas where Cotiviti is actively working to shift audits from post to pre. First, with specialty drug audits. So historically, we've addressed what we call cross-benefit duplicate billing for high-cost specialty drugs in our really only our post-pay data mining audit program. In these cases, a pharmacy benefit manager, PBM, claim is submitted correctly for the supply of the drug. But then what we're seeing a second claim being billed through the medical benefit, billing for that same drug, typically tied to the administration of that drug. It's a common mistake and it's tough to catch since it crosses 2 different benefits, different claim adjudication systems. Still, we've saved health plans millions by identifying and recovering these overpayments. But now we're shifting this audit upstream into the prepay space using our MedRx solution under the prepay audit. By integrating pharmacy and medical data before payment, we can flag cross-benefit drug duplicates in real time and stop the overpayment before it happens. This reduces provider abrasion and drives cleaner claims upfront. The second way here, we're shifting upstream to improve payment accuracy is Cotiviti's prepay coordination of benefits solution, which confirms primacy before any other edits are run. This helps health plans avoid paying claims that should go to another payer, reduces provider abrasion, and accelerates accurate payment. It also minimizes downstream recovery work and supports cleaner claim routing, freeing up resources and improving the overall member experience.
All right, thank you, Matt. I think before we get to some Q&A, I want to give Amy Hodges the last word. I know you started this with talking about the telehealth CPT codes, so I'm guessing you're going to end on that. And what do we do?
Yeah, so I think, I think the most critical thing for providers, payers, and vendors is just to continue to monitor the CMS website and the guidance from them, as well as the AMA. All of these the changes and in legislation, and different payers paying different, codes, it's going to cause an increase in editing, and in claim denials. So far, Cotiviti has seen a gradual increase in edits around these codes. We have seen the codes coming in, but nothing out of the ordinary. So that's good. I think there were a lot of rules impacted by these codes. So the Cotiviti library has been updated. I have a team of physicians and nurses that are maintaining these rules and creating new rules around the codes. And they're flexible and can be customized per CMS or AMA guidelines. I think the payers are going to see higher utilization just because of the convenience of telehealth. And also the lower cost associated with telehealth. I think they're going to see more claims. They could also see more claims from certain areas, since the geographical restrictions have been loosened. So that's just something to watch out from the payer side. But yeah, again, just monitor the CMS website and the AMA website I'm sure there will be more changes to come. So thank you.
Thank you. Yeah, I'm sure there will be. So I think with just a little less than 15 minutes left, I wanted to turn it over to some Q&A, take advantage of the great minds that we have here on the panel. Remember, if you do have a question, I see that many of you have asked, which is great, but if you don't know or you missed it at the beginning, use the Q&A chat function, ask your question, and then we'll see if we can answer it for you. While you're looking at that, I wanted to again plug the full webinar series for the year. Make sure to sign up now, and that way it'll just be on your calendar. And if for some reason you can't make it, I think you'll still get the email that gives you the recording too. The next session coming up in June is it's going to greatly expand upon some of those Cotiviti data-driven trends that I kind of just teased up front, and we'll take a deep dive into that from some of our analytics experts. So let's jump into the Q&A. Let me pull that up. And really the first question does tie into that analytics. Someone asks, to what do we attribute the 17% increase in E&M level 4 and 5? And I'll start by saying that I pulled that stat from our analytic team, and I do know that they can get me the reasons for that. I don't have it on hand, but I do know, in fact, there's that team is producing a white paper that's going to be coming out very shortly, all about the E&M increases. But until then, I don't know, Amy Hodges, any idea specifically?
Just off the top of my head, part of me thinks it could be what I was just talking about with the accessibility of telehealth. More people are going to the doctor because it's easy. So that could be part of it, but not 100% sure.
And I know there's an increase in emergency department facility as well in our data. So I'll look for the person that asked that. I'll look to see if we can get a more detailed answer for you on that. So I will move to the next one then. Have you seen the increase in home and community-based and value-based programs support payment integrity efforts? Not sure who that would go to. Have we seen an increase in home and community-based and value-based programs support payment integrity efforts?
I can kind of high level hit on it. I think we've definitely seen an increase, but when it comes to payment integrity, it's really been mixed, right? So challenges being lack of standardization across the states and the plans. And really at the end of the day, the programs that support the payment integrity in theory really require that standardization. So I think stronger data standards, real-time oversight are really what is needed here to fully realize their payment integrity potential.
Okay. If no one else has anything on that. Next question says, this goes to Amy Carlton. In what ways do you currently use AI to support payment integrity, and challenge do we currently see?
Yeah, so to summarize, AI is a part of our toolbox. It is not our primary driver. So we leverage AI with our data scientists, with our medical directors, our content team. There's a whole robust group that is leveraged to do the research, to build the algorithms, to be able to hone in on those right claims, to be able to find those overpayments. And so with that, we leverage being able to identify the right claim, leverage the AI through our data scientist build. But at the end of the day, we're doing that clinical coding and documentation validation for inpatient or outpatient reviews, which still needs that human touch. So again, AI is part of the toolbox, but we still leverage our human touch to perform that review, ensure that it's accurate, take a look at it clinically, to coding, to documentation, to see that what's in line with the billing and coding guidelines is what was billed back to what was the treatment that the member received. Because at the end of the day, we want to make sure that the treatment the member had received while inpatient or outpatient still is documented accurately, that then goes to coding and billing accuracy, that goes to the right payment. So all of those steps and milestones have pieces of AI in them, but again, it's part of our toolbox, but not our number one driver. Back to you, Warren.
Okay. Thank you. So I think this ties to telehealth, Amy H. Why are all commercial payers not allowing the new telehealth codes?
Well, I mean, so I think typically a lot of commercial payers will follow Medicare. And they will take time to monitor the reimbursement patterns. They will, and so they don't uniformly adopt new codes right away. So I think eventually they may, but right now, I mean, going out and looking at commercial payers' websites, it's all over the place. Some are accepting new codes, some are not. So again, just continue to monitor, and hopefully eventually we'll start seeing more of these new codes.
Okay, fair. I think this probably to you, Matt. What kind of policy changes are you seeing around GLP-1s? I know you mentioned some of them.
Yeah, I mentioned a few of them across different health plans, but at the end of the day, we're seeing just more restrictive policies coming in 2025, right? So those higher BMI thresholds, tighter prior authorizations, and coverage limited to conditions like diabetes or cardiovascular risk. So it's just, I can't stress the importance of this, just ensuring that these are being tracked by your vendor, by really different payer policies, and by really the geography as well. And not just pre and post, right? You want to make sure that you want to make sure that it's being tracked and implemented within your pre and post programs to ensure that post-pay audit is capturing any leakage that may fall through your prepay edits.
Okay, I'll keep you on the hot seat. I think this is for you as well. How does Cotiviti use pricing transparency data in post-pay audits? I think maybe you touched on that a little.
Yeah, but I'll just stress it again. The machine readable pricing files, right? We all know we love our acronyms here in healthcare, but the MRFs is really just there's a need to ensure that you're integrating those into your systems for that pricing validation tool. This is going to give us real-time visibility into lot amounts, billing modifiers, and drug unit measurements. If anybody's familiar with the drug unit versus kind of the drug dose as well, it's billing drugs is difficult because one HCPCS unit doesn't always equate to 1 milligram, right? One HCPCS unit could equate to 5 milligrams or 10 milligrams, which creates that unit conversion issue. And in turn, right, creating overpayments and leakage there. So it's just really important to integrate these MRFs into your systems.
Okay, thank you. Amy Carlton, I believe, or anyone, but you mentioned this. Do you see the trend in the outpatient space continuing to grow until a point that it will have a higher spend even than inpatient at some point?
I think that's a great question. I don't know. I wish I had a crystal ball for that one, but I definitely see the trend in the outpatient space growing. As I shared, it is the advanced technology that's existing within the hospital system that is having less invasive procedures, being able to have folks receive their procedure and go home. As a nurse, I can tell you I have recovered numerous patients myself from surgeries, and the best thing that they always ask for is how can they go home to recover. So I do see that trend from inpatient to outpatient is not going to stop. It is going to grow, and it is the benefit to the member at the end of the day who needs that procedure to be able to go home after it. So I think the outpatient space is definitely an area to monitor. And see what other procedures are shifting from an inpatient only to an inpatient outpatient, depending on the patient's comorbidities, but definitely an area to watch as science advances for surgeons, that means we should be watching the spend shift as well.
Okay, thank you. A couple more questions. I think this next goes back to you, Matthew. You mentioned a Cotiviti prepay COB solution. Question is, how does that differ from traditional COB processing?
Yeah, it's timing and accuracy, right? So, like I said, we verify primacy before any other edits run. So, and this is going to help avoid false denials and reduces rework. And our system uses real-time eligibility and predictive logic to catch those COB issues early. And at the end of the day, it's going to reduce administrative costs, provider abrasion, and while improving that claim accuracy. And also, as we know, it really just removes the pay and chase model of post-pay auditing if you're capturing all of that in a prepay or a pause and pay solution.
Okay.
Also, right, real quick, Warren, before, but just we all know there's different exclusions in Postpay too. That obviously, if you're doing it within a prepay setting, it actually captures and allows recovery on claims like host claims within the Blue Cross Blue Shield audits. So, just a really good solution to have upstream and move upstream into that pre and pause space.
Thank you. All right, I think we have time for one more, and maybe this person missed the very beginning, but the question is, with so many changes happening in 25, how does Cotiviti help clients stay ahead? And I know I'll give the marketing answer. When I first said we don't know all the changes, it's a little wait and see, but when it does come to helping with those real changes and staying in front of the regulation updates and so forth in our solutions. I mean, we've got a lot of reading for you out on our website. We've got this webinar series you see in front of you here. Definitely sign up for those. I think June is going to be a great one for us as far as like billing and utilization trends go. The case studies and podcasts. And for those of you that are clients, definitely consider attending our client conference because we're going to have some more conversations there. That's in June. And so, who knows what's going to take place by June. So we'll have a lot of panel discussions and roundtables there as well. So I'll just start with top. Amy Hodges, any kind of last comments on how does Cotiviti help clients stay ahead?
We're just trying to stay on top of the rules and make sure that they're maintained and accurate so that the claims are paid appropriately. So that's my team's goal.
Amy C?
Yeah, the same thing is making sure keeping a pulse on both inpatient and outpatient, and with the latest policy and regulation updates to ensure that those claims are being billed accurately from the beginning.
All right, last word, Matt.
Yeah, I mean, I think internally here at Cotiviti, we have vast amounts of data, and obviously we have different teams, right? Pre, post, and every team in between. And I can honestly say we collaborate internally to monitor those payer policy updates, any CMS rule changes, all the pricing shifts and utilization trends. So you have that full range of multiple different solutions internally here at Cotiviti monitoring that.
Yeah, and I will say too, I mean, for those of you that are clients, just ask your client engagement leaders. We have inside and outside counsel that can maybe help address some of those regulatory questions that you might have. So, all right, we are just 1 minute past the total time of 45 minutes. So this does conclude today's webinar. Thank you so much, Amy, and Matthew. We'll be reaching out to all of you via email shortly with a link to the on-demand recording of the webinar. And as soon as this session ends, you'll have an opportunity to answer a survey about your experience today. Please do that. That helps us continue to get better. I'm Warren Lesnevsky. Thanks for joining us today, and we look forward to seeing you again at the next 3 webinars.